Okay, hello everybody. I still have my stuffy nose and sore throat, but here we are giving you the monthly quiz. It's that third Thursday, I guess, in the month. So let's get started, and I have 10 excellent cases to show you. And here we go. First case. This is a vet with fever. You see a large cystic mass in the liver, multiple cystic lesions inside this mass. You can see it a bit better here. So you say to yourself, cystic lesions is not a simple cyst. It's not like polycystic kidneys. What is it? It could be a mucinous tumor of the liver, but they usually don't have so many cysts. And look how many cysts you see on the cinematic. And I said the vet, that's veterinarian, not a vet of wars. And so you have to say, aha, this patient's around animals. We got to be thinking something a little different. And this was a great case of hydatid disease. Really classic example. Right upper quadrant pain in a 12-year-old. There's an infiltrating tumor in the liver. There's areas of calcification. There's areas of necrosis. There's areas of vascularity. Now, it looks like an aggressive tumor. In a 12-year-old, you rarely see hepatomas. You can see fibrolamellar hepatomas in teenagers, but unlikely in 12-year-olds. Large liver mass, 12-year-old patient, looks aggressive, looks malignant. The most likely diagnosis, neovascularity, is going to be hepatoblastoma. It's an unusual tumor, often very aggressive, large, and this is a really nice example. Incidental finding, there's a mass by the left adrenal. Is cystic with rim enhancement. Does not have the look of an adenoma. Could it be an infarct, a prior bleed? That's a thought. Could it be a adrenal cortical carcinoma? They can be cystic. Could it be pheochromocytoma? That can be cystic as well. It's kind of unusual to look at non-contrast. Contrast, you see the cystic lesion, you see the cystic component, and you see the rim a lot better on the vascular part. So what am I thinking? I'm thinking, boy, this probably needs to be removed. I don't think it's a adrenal cortical carcinoma. If the patient had a history of malignancy, this could be a MET. You might think about things like melanoma. Doesn't look like lymphoma. And then on PET, it's hot. So a cystic lesion, prominent rim, low density, hot on PET. I got to be thinking malignancy, primary versus metastatic. This was removed. There was a schwannoma. Schwannomas can be low density. They can have a slightly enhancing rim. This is a really, really tough call. I don't think anyone's going to leave this lesion behind. No one's going to biopsy it. The right treatment is what was done, taking it out. But what a great case. Hematuria. Infiltrating tumor in the left kidney, upper 2/3. Hypodense. Could be a renal cell carcinoma. If it was, it would be a papillary, not a clear cell. Contralateral right kidney is normal. There look like a few small nodes. You can see the tumor is infiltrating the upper 2/3 of the left kidney. It involves the vessels. You don't see the calyces as we go on later phase imaging. So now you're thinking, okay, I know this is a tumor. I know there's nodes. It could be a papillary RCC. It could be lymphoma. It could be metastasis. But with the lack of visualization of the calyces, you do always still need to think about transitional cell carcinoma, although you like to think about them being smaller and involving the calyces and destruction, but they can be large masses involving the calyces with lack of visualization. And this, of course, was a transitional cell carcinoma, a really nice example. Another case, what about the kidneys? There's patchy enhancement of the kidneys. The cortex is low density, the medulla is higher density, and it's involving both kidneys. The other thing you see is that the mesenteric vessels are small, the bowel is edematous, the renal arteries are small. Look at the patchy enhancement with the lack of good cortical differentiation. And with the small celiac and SMA, you're saying, well, this is not just the kidneys, but it's multi-organ. If you look at the liver and the spleen, they're really not enhancing. Coronal views, the kidney has this patchy enhancement, peripheral lower density, central higher density. This is the appearance of someone with a low blood flow state. Patient's hypotensive, explains the lack of good enhancement of the liver and spleen, explains the small vessels, and also explains this patchy, decreased attenuation of the cortex. A really, really nice example, beautifully shown, particularly on the coronal and the coronal 3D volume rendered image, which you see here as well. And this was a hypotensive patient with developing shock in the kidneys and the other findings of small vessels, poor liver and splenic enhancement, poor bowel enhancement as well. Patients are weak post-colonoscopy. There's a cystic lesion. Maybe it's a bleed. It's not coming off the kidney. It's near bowel. But the bowel, I don't see free air. I don't see bowel obstruction. You know, with colonoscopy, you do have complications, perforation of the colon, injury of the spleen are possibilities. This cystic lesion is interesting. Well, what is it? Well, this is an ovarian cyst with torsion. And in fact, it was a serous cyst adenofibroma, which is a benign lesion. The colonoscopy somehow moved things around a bit and forced that ovary to twist on its axis, and the patient now developed a torsed ovary. So we don't think about torsed ovary, we think about it as acute onset of abdominal pain. But when you think about post-colonoscopy, perforation, injury to spleen, and issues with the ovary should be considered as well. Abdominal pain, cystic lesion tail of pancreas with calcifications. Calcifications, you could think of a neuroendocrine tumor. If the patient's younger, you might favor a SPEN tumor. Other calcifications can be seen like in serous cystadenomas. There's no dilated pancreatic duct. There's nothing else. It's not the look of chronic pancreatitis. Here it is nicely again seen on the cinematic rendering. And this was a SPEN tumor. Truthfully, my favorite prediction here would have been a non-functioning neuroendocrine tumor. Here's another one, similar location, lesion tail of pancreas. It's denser than the spleen. Otherwise, you could have considered a splenule, and you should still consider it. There's some calcification. It's hypervascular compared to the rest of the pancreas. And again, although I think about splenules, the other thing I think about by the tail of pancreas is a neuroendocrine tumor, and sometimes it can be challenging to distinguish the two. This was a very nice example, as shown in the cinematic rendering, and was a neuroendocrine tumor of the tail of the pancreas. Another case, back pain, complex cystic lesion by tail of pancreas. There are septations. It's not the good look for a neuroendocrine tumor or metastasis. It could be a serous cystadenoma with a thin septation. It could be a large IPMN. It could be a lymphoepithelial cyst, but those are usually more eccentric. It could be an MCN, a mucinous cystic neoplasm. It's a great location for it, and they do commonly have septations. Usually 40-ish-year-old female is the classic description. Here it is with a few more images, septations, some rim enhancement, and this was a mucinous cystic neoplasm, or MCN, a really important diagnosis. Last case, I think, abdominal pain, complex cystic lesion with septations. I'm thinking about ovarian mass, maybe ovarian cancer. Could be a large abscess in the pelvis, but you don't have a history of something to suggest a perforation. I don't see free air. Complex ovarian mass is something to think about. One of the things that mimics complex ovarian lesions is endometriosis. They can be solitary or multiple, they can be small, they can be large, they can be anywhere in the pelvis, on the ovaries, on the uterus, in the canal. A great example of endometriosis. Well, that's it. I showed you 10 cases. I hope you enjoyed seeing them. I hope they were helpful, and I hope you have a great day. See you later, everybody.